my lecture outline, I will talk about briefly on background and introduction, and then we will move on to the diagnosis of rheumatoid arthritis. After that, we will discuss about two cases, and finally, a bit of management and also discussion on the case illustration. So background, rheumatoid arthritis, or RA, is a systemic autoimmune disease which primarily affecting the joint. So when you have chronic synovial inflammations, it leads to progressive damage to articulate. The chronic synovial inflammation in rheumatoid arthritis will lead to progressive damage to the cartilage and also bone, and eventually will result in disability. Therefore, it's very, very important for us to control the articular inflammation to prevent the joint damage. So let's take a look at this figure, the developments and progressions of rheumatoid arthritis. Let's say the patient has susceptible to rheumatoid arthritis, but at that point of time, they have a healthy joint. So, which type of patient actually susceptible to rheumatoid arthritis? For example, when they have a family history of rheumatoid arthritis, they have probably smoker. So what happened? There is initiations of autoimmunity. The initiations of autoimmunity whereby you have formations of rheumatoid factor, the formations of anti-CCP. So this is when you have uh, cell infiltration to your synovium. So this is what we call as preclinical rheumatoid arthritis. Subsequently, the immune cell infiltrate all your synovium. You start to have undifferentiated arthritis, and eventually, when you have cell full-blown immune cell infiltration, hyperplasia of the synovium, and also planus formation, this is when you have established rheumatoid arthritis. How to control or prevent joint damage in rheumatoid arthritis? We can do this by, number one is start early treatment with disease modifying treatment. Number two is to control the disease activity better by doing treat to target strategy. And finally, the developments and use of novel disease modifying drug, which include biologic. Okay, we will move on to second part of the lecture, which is the diagnosis and screening. So how do you diagnose rheumatoid arthritis? In our rheumatology clinic, we are using the 2010 ACR, American College of Rheumatology, and European League Against Rheumatism, EULA, classification criteria for rheumatoid arthritis. This classification criteria have 4 domains. Number one is the joint distribution. You will get more marks if you have more joint involvement, especially if it involves more small joint. Number two is serology. When you have high positivity of rheumatoid factor or CCP, which is what we consider as 3 times of upper limit normal, you will get 3 marks. If you have normal CRP, you will have 0 marks, and the domains also include symptom duration, which is less or more than 6 weeks. So when you classify as RA, rheumatoid arthritis, if you have more or equal than 6 of point of the domains that I have mentioned before. So what if the score is less than 6? Number one, the patient still can fulfill if cumulatively, basically over time, it will fulfill other domains. Let's say initially the RF is negative, but anti-CCP later come back as positive, or retrospectively. Basically, at 4 domains you have adequately recorded in the past. So it still can be diagnosed as rheumatoid arthritis. So the S factor. The S factor is actually the three S factor that we usually ask for screening in inflammatory arthritis. Number one is swelling. Do you have persistent swelling over more than one joint? This is especially at the small joint of the hand or feet, which is particularly in metacarpophalangeal joint. Number two, the second S is stiffness. You can ask the patient whether she has early morning stiffness of more than 30 minutes. And the third S is squeezing. In our clinic, a quick screening test is include the MCP, where you actually squeeze the metacarpophalangeal joint. Uh, you squeeze softly and you will actually elicit pain. This is actually indicate subclinical synovitis. So can we do screening in early inflammatory arthritis? Yes, in 2016, EULA come up with this recommendation in management of early arthritis. They actually talk about screening in this recommendation. I will talk briefly on this recommendation in this slide. So on my left hand side, this is for diagnosis. So let's say the patient has early arthritis. What classify as early arthritis? When the patient has swollen joint, patient complains of pain, stiffness. So let's say from the history and clinical examination, you can diagnose patients specifically, let's say for gout, then you will treat as per gout. But let's say you cannot classify the patient to any of definite arthritis, then probably the patient will have undifferentiated arthritis. And you will look at the risk factor, such as rheumatoid factor, the joint involvement. If it yes, you will need to go to the management, which is on the right hand side. Briefly, this recommendation actually recommend early treatment, and the first line is always methotrexate unless contraindication. Okay. Now we move on to our case study. Case number one, a 47-year-old lady comes to your clinic. She complains of bilateral hands and wrist pain that began about 3 months ago. So, what are further questions